obvious changes in the optic nerve head in a glaucoma suspect?
So good morning everyone. So without wasting much time, now why is optic disc examination so important? Well, especially in glaucoma suspects, the optic disc and the nerve fiber layer changes usually occur first, much before the field defects occur. The intraocular pressure and visual field assessment in themselves, they lack diagnostic sensitivity if you're not backing them up with a corresponding corresponding optic nerve defect. Now, what I mean to say is careful examination of the optic disc allows us to detect early and pre-perimetric glaucoma. Now, there are methods of clinical examination. You can use a direct ophthalmoscope, but then it's not very accurate. It lacks stereopsis. The gold standard of doing an optic nerve measurement is slit lamp biomicroscopy using non-contact lenses, because it gives you a good stereoscopic examination and also allows you red-free light examination for the RNFL. Now, if you're using a direct ophthalmoscope, use the Gross's technique, wherein a 5-degree aperture produces a circular spot of a diameter of 1.5 millimeters, and this is how you assess the optic nerve head size. If you're using the slit lamp biomicroscope, adjust the height of the slit lamp beam to coincide with the vertical edges of the optic disc and read the scale on the slit lamp. Now, this has to always be multiplied by a correction factor depending on what lens you're using. If it's plus 60, the correction factor is 1, and so on and so forth. Now, it's always a good practice to have a documentation of what you see. You should have a baseline documentation of your optic disc and serial photographs so that you can pick up early progression. Now, stereo photographs are the gold standard, but even if you don't have this in your practice, or if it's not affordable to your patient, optic disc diagrams is a very good method of doing documentation. Now, this is how a normal optic nerve looks like. The neuroretinal rim, which is basically the amount of retinal nerve fiber layers that are contained in the optic disc that leave the eye, they follow a simple rule, which is the isn't rule, which means that the inferior is the thickest, followed by superior, nasal, and temporal. The cup is basically the empty space within the optic disc, and the horizontal cup is longer than the vertical cup. So, any elongation in the vertical cup is what needs to be looked at suspiciously. Now, there can be a lot of physiological variations in a normal disc. The EUGS guidelines says that the use of CDR alone, the cup disc ratio, to classify patients is not recommended, and attention should be focused on the disc area. So, if you see all of these three discs, the amount of rim area and the number of retinal nerve fiber layers that are contained in a small disc with a CD ratio of 0.2 is exactly equal to the number of nerve fiber layers that are passing through a large disc with a CD ratio of 0.8. So, CDR in itself doesn't mean very much when you're not correlating it with the size of the disc. Neuroretinal rim, like I said, is the area between the cup and the disc margin. What is important over here is to delineate the cup margin. Now, usually follow the course of the vessels. The circumlinear blood vessels, they rest on the inner margin of the neuroretinal rim or the edge of the cup, like you say. Now, cup disc ratio is nothing but just a ratio of the cup diameter to the vertical disc diameter. Horizontal is usually larger, vertical is lesser, so any elongation in the vertical CDR has to be looked at suspiciously. But again, I cannot emphasize more that the cup disc ratio is just a surrogate for the neuroretinal rim. It varies with disc size. A large cup can be normal for a large disc. On the other hand, a small cup may be abnormal for a small disc. CDR in itself doesn't mean very much. It can be fallacious. So Chandler and Grant, in their first edition way back in 1986, they quoted, "We have found that assessment of CDR is practically useless in management. The neuroretinal rim and the contour of this tissue is a key parameter that needs to be assessed." So now let's look at these two examples. Which out of this do you think is normal? Any takers? The right one. Okay. So let's look at the first one. So this is a small cup. Like I said, a small cup can be abnormal for a small disc. So what you need to concentrate upon is the nerve fiber layer defect. You need to concentrate on the retinal nerve neuroretinal rim, and you need to concentrate on the vessels. Over here, if you see that there is a absence of the inferior neuroretinal rim, there is a very evident beta zone. So this is basically a pseudo-normal glaucomatous mini cup. Now, when you look at this picture, it is a large cup, but it's also a larger disc. And it's very conveniently following the isn't rule. The rim looks very healthy, but this is basically a pseudo-glaucomatous cup in a large disc. So there are many signs in to pick up glaucomatous optic disc, but for all practical purposes, you can very easily remember just these 5 rules, which can be remembered with a very simple mnemonic. Simple rules have no problem. You need to look at the size of the disc, the neuroretinal rim, hemorrhages, look for nerve fiber layer defects, and look for a peripapillary atrophy. There are many other ancillary signs, but many just depend on CDR, so this is what I want to de-emphasize over here. So now I'll be elaborating just a few signs which you're more likely to find in a glaucoma suspect. Now, notch can be very subtle in the beginning, but it's a combination of a couple of signs that gives you more of a sensitivity to rule in glaucoma. So if you have a notch, like in this one, there is an inferior notch over there, you will also have a corresponding inferior nerve fiber layer defect. Then a saucerization, or what you say a sloping disc, can be an early sign of glaucoma. So in this, there is basically a diffuse shallow cupping that extends till the margin, but the normal neuroretinal rim color is maintained even in the area of a focal saucerization. Nasalization of vessels doesn't mean very much. The first picture shows you a large disc with no glaucoma but nasalization. In the second picture, there is advanced glaucoma but no nasalization of vessels. Now, a concentric cup is basically where the neuroretinal rim has been lost somewhat everywhere, and it should be looked at suspiciously. Now, disc asymmetry between the two eyes can mean either asymmetry in the size of the cup, or the width of the NRR, or the vessel course, peripapillary atrophy, either of these 4. Now, in asymmetry of CDR, the cup disc ratio of more than 0.2 between the two eyes, when the disc size is similar and there is no anisometropia, has greatly increases the index of suspicion for glaucoma. Now again, like Dr. Sujata mentioned, look out for Dran's hemorrhages. They're very rare in normals, and they can very often precede RNFL defects, notching, or visual field defects. The bearing of circumlinear blood vessels, bayoneting, all these are signs that one needs to consciously look out for. Now, retinal nerve fiber layer defects are better visualized at the posterior poles, especially at the vertical poles of the optic nerve head in an arcuate fashion. Green light is the best method to diagnose it. Why? Because green light has a shorter wavelength, so it falls short of the red light, and all the superficial structures, whether it's epiretinal membrane or Dran's hemorrhages, RNFLs, all the superficial structures are better visualized under green light. So you can have slit defects, or you can have wedge-shaped defects, or you can have diffuse RNFL loss, which is slightly more difficult to pick up clinically. Now, peripapillary changes can be of 2 types. The alpha zone atrophy, which is the outer peripapillary atrophy, is present in almost all normal individuals, but the presence of a beta zone atrophy is what needs to alarm you a little, because it's more frequent and more extensive in patients with POAG and NTG. Okay. So now let's look at this example. So this is a disc. Now, if you look at it objectively, now in the first look, you know the arrow is pointing towards a focal atrophy point. Then you can also see bearing of circumlinear blood vessels over there. There is also laminar dot sign. So this is basically a very obviously a glaucoma looking disc. Now, what about this one? So again, like if you follow the mnemonic and look at it objectively, look at the size, the rim, hemorrhages, presence of any nerve fiber layer defects, any peripapillary atrophy, you would pick up multiple signs over here. There is inferior hemorrhage. It's probably average to a large size disc, and there is bipolar notching over here. Now, what about this one? So if you're very quick in coming to a diagnosis in the first glance, you might just say this is a normal disc. But again, if you look at it very carefully, give it a few more minutes, you would know that there is a very evident inferior disc hemorrhage over here, which is better demarcated in a red-free filter examination. So Dr. Josh Jonas is also called Dr. Disc, and he had these 3 rules which said, until proven otherwise, all glaucoma suspects have disc hemorrhages, all glaucoma suspects have RNFL defects, and all myopes have glaucoma. So now these are very strong statements to make, but what he's trying to say is that in all glaucoma suspects, consciously look out for disc hemorrhages, consciously look out for RNFL defects, and always have a very high index of suspicion in all myopes. So what about this disc? So this is clearly not a very typical of a glaucomatous disc. This is most probably a congenital disc anomaly. These are again congenital disc anomalies. Now what about this one? Is this a glaucomatous disc? It is a large disc. The CDR seems to have increased in size vertically. But if you notice very carefully, there's something funny about the shape of the disc and also the course of the vessels. So this is basically a dysplastic disc. Now what about this one? This is again impossible to interpret clinically. This is a myopic disc in which one needs to have a very high index of suspicion. Now myopic discs are usually tilted discs, and these are tilted temporally, so it's very important that you delineate the disc, the temporal margin of the disc from the margin of the peripapillary atrophy. Now for a glaucoma suspect, it's very important that one differentiates a glaucoma suspect from a completely non-glaucomatous optic neuropathy. Now in a glaucoma suspect or a frank glaucoma, glaucomatous disc, you'll have a typical loss of rim. You can have an enlarged cup. You can have a beta zone peripapillary atrophy. There will be no rim pallor, and you can support it with typical glaucomatous field defect findings. But in a pseudo-glaucomatous atrophy, the NRR will be pale. You can assess the color of the intact rim in all the quadrants of the disc. They will be supported with typical neuro-ophthalmic field defects, and you can also check the color vision just to be sure. Now what about these discs? Do they look glaucomatous? So they are unusually too pale. So always consider a complete clinical picture when in doubt. Now what about this one? So this is a patient who has a BCVA of 6.6 in the right eye, 4/60 in the left eye. The left eye disc is pale. Over here, the giveaway is actually the right eye. So this example is basically given just to stress that examining both the eyes are very important. So in the right eye, there's a small crowded disc. So this is most probably an NAION of the left eye. Now this is a suspicious looking disc again with a normal IOP and a normal automated perimetry. Is it a neurological disc pallor? So there is a very striking temporal pallor over here of the NRR. But is it glaucomatous or is it neurological? So again, the subtle sign to be picked up over here, which can be missed easily, is the superior notching. So the RNFL OCT confirms that there is a superior RNFL thinning along with the notch. Now all these kind of discs, whether it's coloboma, optic disc pit or tilted disc, these are all disc suspects, and you will not be penalized in over-investigating these patients with a perimetry. Of course, I don't need to emphasize the fact that RNFL OCT has no role in any of these sort of morphological discs. So all of these discs need to be evaluated and investigated if you cannot interpret them clinically. So just a few clinical pearls to take home. Always it's a good practice to draw diagrams because it helps in developing skill for evaluation, also brings down the cost for your patients for not having a photograph taken every time. Document the progression of with ONH photos if possible. The diameter of the disc has to be taken into account whenever you're assessing the disc with a CD ratio. Trans hemorrhages, defects in the RNFL need to be consciously looked out for. And always mention the dimensions or the contour of the NRR, not the color. That's important in glaucoma. Disc asymmetry needs to be looked out for when comparing both the eyes, and always keep the differential diagnosis in mind. Thank you.